Imagine a light, cool breeze blowing right across your arm, and your brain somehow registers it as a third-degree burn.
Oh, yeah.
Or, just a regular cotton T-shirt brushing against your shoulder. But to you, it feels like someone is dragging actual barbed wire across your skin.
Right, which sounds unbelievable to most people.
It really does. But for millions of people recovering from what are, considered completely routine, successful surgeries, this isn't some abstract medical concept or a nightmare. It's their daily waking reality. Welcome to the Deep Dive, by the way. If you are the learner joining us today, we are so glad you're here.
Absolutely, and it is a devastating reality for those patients, and it stems from something we usually dismiss as completely harmless. I mean, we tend to view a surgical scar as the end of a story, right?
Yeah, totally.
Yeah.
You get a cut, the doctor sews it up, stitches come out, and you're just left with a cosmetic blemish.
Exactly. We think of it as this permanent dead monument to an old injury.
But today, we are answering one massive question for you. Can surgical scars fundamentally alter how your body feels the physical world?
And spoiler alert, the answer is yes.
Big yes. We're digging into this huge stack of anatomical research, clinical guidelines, and pain specialist protocols today. We've got some really fascinating insights from anatomy and human movement. We're going to look beneath the surface of the skin, and I promise you, by the end of this deep dive, you will never look at a healed wound the exact same way again.
You really won't, because to actually grasp what goes wrong when a scar forms, we have to look at what happens the exact second a surgical scalpel breaks the surface of the skin.
Okay, let's unpack this, because if we're talking about a scalpel making that initial incision, what are we actually cutting through in terms of sensation? I mean, I think most of us just think of skin as a protective wrapper.
Right, a wrapper. But it's much more than a wrapper. It's actually the body's largest organ.
Oh, wow, really?
Yeah, an average adult, it covers about 1.8 square meters.
That's huge.
It is. And while it is incredibly thin, I mean, we're talking usually just 1 to 2 millimeters thick, the layer just beneath the surface, which is called the dermis, is this astonishingly dense, sophisticated sensory array.
So it's packed with sensors.
Densely packed, with very specific mechanoreceptors that are designed for highly specialized jobs.
Give me an example, like how specialized are we talking here?
Well, deep down in the tissue, you have these structures called Pacinian corpuscles.
Pacinian corpuscles.
Right, and these basically act as your heavy-duty sensors. They pick up deep pressure, vibration, but then much closer to the surface, you have Merkel's discs.
Merkel's discs.
Yeah, and these are densely packed into areas like, your fingertips and your lips. They process very light discriminative touch.
So Merkel's discs are what allow me to type an angry email without actually having to look down at my keyboard.
Yeah.
They give that really tiny microfeedback.
Exactly, yeah. They provide this high-definition tactile mapping of the world. But what's fascinating here is that all of these receptors and the skin itself, they aren't just draped loosely over your bones.
Right.
The skin is under constant natural tension, even when you are lying completely still.
Which is so wild to think about. So think about it like a piece of wood, because wood has a very distinct natural grain. And in the human body, anatomists actually map out this grain using something called Langer's lines or cleavage lines.
Yes.
They essentially trace the natural internal stress and tension across different areas of the body, right?
They do, and this natural tension dictates the entire future of a surgical wound.
How so?
Well, if a surgeon makes an incision parallel to that grain, along the Langer's lines, the wound edges naturally just want to rest against each other.
Oh, so they kind of naturally close themselves.
Exactly. You end up with a clean, very minimal scar, and honestly, a much higher chance of preserving all those delicate sensory receptors we just talked about.
But I imagine a lot of surgeries require doctors to cut against the grain, right? Just to access whatever organ they need to fix underneath.
Oh, it happens all the time. And when a surgeon cuts perpendicular to those tension lines, the inherent mechanical stress of the skin physically pulls the edges of the wound apart.
Yikes. So just gapes open.
Yeah, and then the body has to bridge a much wider gap. And the material it uses to bridge that gap, scar tissue, is structurally entirely different from normal, healthy skin.
Okay, so the surgeon makes the cut, the skin pulls apart because of that tension, and the body has to patch the hole. What is actually happening, on a cellular level, to create that patch?
So when tissue is damaged, the body basically sounds a massive biological alarm.
Like a siren going off.
Exactly. And these specialized repair cells, which are called fibroblasts, they just flood into the site.
Fibroblasts.
Right, and their primary job is to manufacture and lay down collagen.
Which is the main structural protein, right? Like the building blocks of our connective tissues.
You got it. Now, in healthy, uninjured tissue, collagen fibers are beautifully organized. They run completely parallel to each other.
Nice and neat.
Very neat. And this neat structure allows the tissue to stretch, to be flexible, and to accommodate all those tiny blood vessels and nerves.
But I'm guessing the body doesn't take the time to rebuild that beautiful parallel structure when it's desperately trying to repair a surgical incision, does it?
No, not at all. It goes into a state of fibrosis. It churns out collagen in this massive, chaotic overdrive.
Oh, wow.
Yeah, so instead of neat parallel lines, the fibroblasts just throw down collagen in a messy, disorganized, crisscrossing web.
See, I have to pause here and just look at this from an evolutionary standpoint. Because, we've had millions of years to perfect the human machine. Like, why on earth would the body do such a sloppy, disorganized patch job instead of just taking the time to rebuild the tissue correctly?
Well, it's a matter of biological triage.
Triage.
Yeah. Evolution has programmed your body to prioritize immediate survival over long-term perfection. I mean, when you have an open wound, the body isn't thinking about, preserving your ability to feel a light breeze.
Right, it's just trying not to die.
Exactly. It is entirely focused on preventing a lethal bacterial infection from entering your bloodstream and, well, stopping you from bleeding out. So it essentially sacrifices flexibility for speed and stabilization.
So it builds a fast, ugly concrete barricade instead of a nicely engineered bridge.
That is a very accurate way to visualize it, honestly. That chaotic web of collagen absolutely saves your life in the short term. But the trade-off is severe.
Because it's not normal skin anymore.
Right. This new scar tissue is thick, it completely lacks elasticity, and it has this really notorious tendency to glue itself to the underlying structures.
Ugh, like what?
Like it binds to the muscles, the fascia, the connective tissues that are normally supposed to just glide smoothly over one another.
Okay, so we survived the surgery. The hole is patched with this dense, thick, concrete-like webbing. But what happens to the nerves? I mean, the surgeon's scalpel didn't just cut the skin, it sliced right through all those tiny sensory communication lines. How do they get through that concrete barricade?
Well, they have to regrow. And nerve regeneration is a breathtakingly slow process.
How slow?
A damaged peripheral nerve only grows back at a rate of about 1 millimeter per day.
1 millimeter a day. Wait, really? If you have like a deep laceration on your forearm, it could take over a year for those nerves to reach your fingertips.
It often does take that long, yeah. And to understand the gauntlet they have to run, you kind of have to look at how a nerve is built.
Okay.
A nerve is essentially a biological electrical cable. The inner wire, the part that actually conducts the electrical signal, is called the axon. And surrounding that axon is a protective guiding sheath.
So if the nerve is sliced, but that outer sheath miraculously stays intact, the axon has a tunnel. Like it can slowly millimeter its way back to its destination.
Exactly. But if that sheath is severed or completely destroyed by the scalpel, the axon is blind.
Oh, no.
Yeah, it keeps trying to grow, but without a physical guide, it just wanders aimlessly. Sometimes it just coils up on itself and forms this dense, highly reactive ball of nerve tissue, which we call a neuroma.
A neuroma. And that sounds painful.
Incredibly painful. Neuromas are often the primary driver of stump pain or phantom limb pain in amputees.
Here's where it gets really interesting, though, because even if the nerve doesn't coil into a neuroma, it still has to navigate that completely disorganized scar tissue we just talked about. I picture it like trying to thread a piece of wet spaghetti through a dense, hardened thicket of briar bushes.
That is a brilliant analogy. The crisscrossing collagen physically blocks the path, and as the scar tissue matures and thickens over time, it can literally wrap around the regrowing nerve.
Oh, that sounds awful.
Clinicians call this nerve entrapment. The nerve gets physically squeezed, compressed, or stretched, taut by the rigid fibrosis all around it.
And when a nerve gets squeezed or stretched like that, it doesn't just go numb, right? It starts misfiring.
Severely. This mechanical compression is exactly why patients report devastating neuropathic pain months or even years after a successful surgery.
Yeah, because it's not the incision healing anymore.
Right. They don't describe typical healing pain like a dull ache. They describe spontaneous electric shocks, intense burning, or a feeling of raw chemicals under the skin.
The clinical sources outline some statistics on this that are genuinely shocking. If we look at back surgeries, for example, There's a condition called epidural fibrosis.
Yes, very common.
That's where scar tissue forms and physically binds to the spinal nerve roots. And the sources say this occurs in 24% to 100% of cases.
It's staggering.
Or in pelvic surgeries, scar tissue can trap the pudendal nerve, causing agonizing chronic pelvic pain that leaves patients completely unable to even sit down.
It's heartbreaking. Our nervous system is profoundly vulnerable to mechanical compression. But what's really crucial here is that the trauma of a trapped nerve does not stay localized to the scar.
It spreads.
Yes. The persistent, screaming irritation from that entrapment causes the entire nervous system to fundamentally alter how it processes all physical touch.
It sets off like a biological chain reaction. Because the sources point out that the transition from normal acute surgical pain to chronic persistent post-surgical pain, or PPSP, affects anywhere from 20% to 50% of all surgery patients.
That's right. And the mechanism behind this transition is called sensitization. And it happens in two distinct stages.
Okay, walk me through them.
First is peripheral sensitization. The nerve endings right at the site of the scar become incredibly hyperreactive because they're just bathed in inflammatory chemicals and constantly being mechanically irritated. So they start firing off danger signals at a much, much lower threshold.
But if that local nerve keeps firing those danger signals day after day after day, eventually the central nervous system gets involved, doesn't it?
It does. The spinal cord and the brain essentially get overwhelmed by this constant barrage of pain data. And this triggers central sensitization.
Central sensitization.
Yeah. The central nervous system literally turns up the volume on all incoming sensory signals. It happens through a process where certain receptors in the spinal cord, known as NMDA receptors, begin to upregulate.
Okay, let's translate upregulate for a moment.
Yeah.
What is the central nervous system actually doing structurally when it upregulates?
Well, it's a form of neuroplasticity. The spinal cord literally increases the physical number of these receptors, and it makes the existing ones much more sensitive to neurotransmitters.
So it's building more infrastructure for the pain.
Exactly. It's the body's way of building a wider superhighway for pain signals because it assumes, based on all the constant input, that you must be in perpetual extreme danger.
It's like a car alarm that gets bumped by a shopping cart.
Yeah.
But instead of just sounding the siren and then resetting, the alarm system actually rewires its own circuitry to become 10 times more sensitive. So the next time a single leaf falls on the windshield, the siren blares at maximum volume.
That is a perfect analogy for allodynia.
Allodynia.
Yes. Allodynia is the clinical term for when entirely harmless, non-painful stimuli are perceived by the brain as excruciating pain.
Wow.
So the input might just be a gentle breeze, right, or the brush of a bedsheet, but the central nervous system amplifies it so aggressively that the brain interprets it as a blowtorch.
Which brings up a massive point of friction in the medical system. Because, a patient experiencing this level of agony will understandably go right back to their surgeon.
Of course they will.
And the surgeon will order an MRI or a CT scan, and the scan will come back completely normal.
Right, because an MRI is designed to look at structural integrity. It will show that the bones are aligned, the surgical hardware is in place, the incision has closed, and there's no tumor or infection.
But it misses the actual problem.
Scans do not show the microcompression of a 1 millimeter thick nerve, and they certainly don't show the upregulation of NMDA receptors in the spinal cord.
So basically, the hardware looks absolutely pristine on the imaging, but the software running the nervous system is completely corrupted. It must be unimaginably isolating for a patient to feel like electric shocks running down their leg, only for a doctor to point at a screen and say, everything looks perfectly fine, you are healed.
If we connect this to the bigger picture, it really requires a paradigm shift in how we understand the human body. Pain is an output constructed by the brain. It is not merely a meter reading of tissue damage.
Right.
A patient can have debilitating, life-altering pain with zero visible structural damage on a traditional scan. And when these neuropathic conditions are unfortunately dismissed by doctors as psychological or just anxiety, they can escalate into a condition called complex regional pain syndrome, or CRPS.
This is when things go completely off the rails. The sources note that with CRPS, the affected limb might drastically change color, sweat abnormally, or become ice cold. But wait, if we were just talking about a trapped sensory nerve, how does that actually cause your foot to physically drop in temperature?
Because the constant barrage of pain signals eventually spills over and hijacks the sympathetic nervous system.
The fight or flight system.
Exactly. That's the system responsible for your fight or flight response, and it controls the diameter of your blood vessels.
Oh, I see where this is going.
Right. When the sympathetic nervous system gets triggered by this chronic pain loop, it can cause the blood vessels in that limb to severely constrict. Less blood flow means the limb physically turns pale and literally drops in temperature.
That is wild.
It is a profound system-wide dysfunction, and it all originates from a microscopic nerve trapped in a surgical scar.
So we are looking at a perfect storm here. The surgical patch is a chaotic web of collagen. The regrowing nerves get physically choked by that web. The central nervous system amplifies the distress signal until a feather feels like fire. And the diagnostic scans show absolutely nothing.
It sounds bleak when you put it like that.
It does. So how do we possibly fix this? Like, how do you treat a completely corrupted nervous system?
Well, the silver lining of neuroplasticity, the very fact that the nervous system can change and adapt, is that it can also be retrained. We can basically hack the software.
Okay, I like the sound of that.
For superficial scars, occupational therapists use a surprisingly low-tech approach called scar desensitization.
I read this part of the clinical protocols, and it seems so counterintuitive. Because they have patients actively touch and stimulate the exact scar that is causing them agony.
It does sound backwards.
Yeah.
But it's a highly controlled, graded exposure. You don't just jump in and start rubbing it. A therapist will have a patient start with the softest possible stimulus,
Like what?
like gently stroking the scar with a wisp of cotton wool.
Okay.
They do this until the central nervous system realizes there is no actual threat, and it stops producing a pain response. Then they slowly graduate to slightly rougher textures, like felt, then maybe terry cloth toweling, and eventually even rough Velcro.
So what does this all mean? It sounds exactly like exposure therapy for a phobia. But instead of treating, a psychological fear in the mind, you are doing exposure therapy directly on the nerve endings in the skin.
That's exactly what it is. And a mandatory component of this therapy is visual feedback. Patients are instructed to look directly at the scar while the cotton wool or the felt is touching it.
Wait, why does looking at it matter?
Because you are forcing the brain to process two completely competing streams of information.
Ah,
The hypersensitized nerve is screaming, "Danger, we are being burned!" But the patient's eyes are sending a visual signal to the brain saying, look, it's literally just a piece of harmless cotton.
and the brain has to choose which one to believe.
Right. The brain is a prediction machine. Over time and with enough repetition, the brain realizes the visual data is reliable and the nerve data is faulty. It actively recategorizes the sensory input, turning down the volume so that the burn goes back to feeling like cotton.
That is incredible. And the protocols also detail something called immersion therapy.
Yes.
If the painful scar is on a hand or a foot, patients are instructed to literally plunge the limb into a bowl of dry kidney beans, lentils, or uncooked rice. I have to say, it sounds like a bizarre punishment from a reality cooking show, just burying your arm in dry legumes.
It sounds so strange, I know. But the neurological principle is totally sound. The constant, varied, multi-point tactile input from all those little beans overwhelms the local pain signals. Therapists also recommend applying vibration to the area, like resting an electric toothbrush near the scar.
Oh, that's tying back to the Pacinian corpuscles we talked about at the very beginning, the deep pressure sensors.
Exactly, you remembered. By flooding those Pacinian corpuscles with mechanical vibration, you force the nervous system to process normal, safe mechanical data. And that essentially crowds out the neuropathic pain signals.
Okay, that makes total sense for a scar on your hand or your knee, but what about the deep internal scars?
Right, the tricky ones.
Yeah, like the pelvic surgeries or the spinal fibrosis, because you can't exactly reach a trapped spinal nerve with a piece of cotton wool or an electric toothbrush.
No, you definitely can't. So for deep entrapments, we turn to highly advanced medical interventions, specifically a field called neuropelviology and procedures like Lion.
Let's break down that term first. Neuropelviology. Neuro meaning nerve,
Right.
pelv meaning pelvis. So the study of nerves in the pelvis.
And Lion stands for laparoscopic implantation of neuroprothesis.
Spot on. So consider a patient who develops severe, debilitating nerve pain after, say, a pelvic mesh implant. The mesh was originally placed to fix a hernia, but scar tissue has formed around it, trapping a nerve deep inside the pelvis. Historically, the surgical reflex was simply to go back in and cut the mesh out.
But removing a synthetic mesh that has spent years fusing with your internal scar tissue sounds like an absolute nightmare. I mean, you would cause massive trauma, risk slicing the bowel, and the original hernia would just pop right back open.
It is incredibly risky.
Yeah.
And it often leaves the patient in much more pain than before. So instead of a destructive removal, neuropelviologists use microsurgery.
They use a laparoscope to navigate deep into the pelvis to locate that trapped nerve, which, remember, might be less than a millimeter thick.
Tiny.
And once they find it, instead of trying to carve it out of the scar tissue, they just place a microscopic electrical electrode directly onto the nerve just above the site of the entrapment.
Oh, so they bypass the roadblock entirely.
Exactly.
But wait, how does sending an electrical shock into an already painful nerve actually stop the pain?
It relies on something called the gate control theory of pain.
Gate control theory.
Yeah. Our nerves have different types of fibers. Pain signals travel along very slow, unmyelinated pathways called C fibers. But normal, non-painful mechanical sensations like light vibration or a gentle electrical hum, they travel along much thicker, much faster pathways called A beta fibers.
So the fast electrical signal literally outruns the slow pain signal on its way to the spinal cord.
Yes. When the fast electrical signal hits the spinal cord first, it triggers inhibitory neurons that essentially close the gate to the slower pain signals that are coming right behind it. The brain never even receives the distress call. The trapped nerve is still physically trapped in the scar, but the brain only feels this soothing electrical current. The patient gets a remote control, and they can adjust the intensity of the stimulation to block the pain, allowing them to walk, sit, and live normally without undergoing a massively destructive second surgery.
That is just phenomenal. I mean, we have covered a massive amount of hidden terrain today. We started with the very first slice of a scalpel across the skin's natural tension, the Langer's lines. We uncovered how the body's desperate evolutionary need to survive a wound triggers this chaotic overdrive of collagen.
We visualized how those delicate, slow-growing nerves get caught in that concrete barricade, and how that local entrapment acts like a virus, upregulating the spinal cord and tricking the brain into feeling agony from just a simple touch.
And finally, we explored the incredibly resourceful ways we can hack the system to fix it. Using everything from visual exposure therapy and dry lentils to microscopic pacemakers implanted deep in the pelvis. It really makes you pause and marvel at how magnificent and complex your own nervous system is. Every single second, it is seamlessly translating the physical world into the feeling of life.
This raises an important question, though, about the importance of early intervention, because it is a dynamic, constantly remodeling system. It's never truly static. It's always adjusting its sensitivity based on your environment, your injuries, and your history. Early desensitization forces the brain to correctly recategorize things before they get out of hand.
Which brings us to the core shift in perspective. We have always been taught that a scar is the absolute end of the healing story. We think of it as a closed chapter, a permanent, dead monument, just like a clean white line on an X-ray of a healed bone. But given everything we've unpacked today, I want to leave you, the listener, with a final thought to mull over. What if a scar isn't a tombstone at all? What if a scar is actually a highly active living sensory organ that continues to secretly communicate with and actively shape your brain for the rest of your life?